In this part 2 of thyroiditis, we will discuss the individual types of thyroiditis, starts from autoimmune to non-autoimmune types of thyroiditis and their cause and pathophysiology. But before we begin, I strongly recommend watching part 1 to understand the pathophysiology of autoimmune thyroiditis, as it will make the remaining topics easier to grasp. Now let's discuss about autoimmune thyroiditis. And under autoimmune thyroiditis, we'll discuss chronic lymphocytic thyroiditis, also known as Hashimoto's thyroiditis. Is the most common thyroid disorder. It is a chronic autoimmune disorder where immune system attack the thyroid gland and gradually decreasing its ability to produce hormones and often leading to hypothyroidism, that is underactive thyroid. It is characterized by a destructive lymphoid infiltration of the thyroid gland and leading to high titer of circulating anti-thyroid peroxidase antibodies in 95% of the population. And anti-thyroglobulin antibodies in 60 to 80% of the population. As we discussed this in part 1, where T and B lymphocytes migrate into the thyroid gland, where T cells cause the direct destruction and where B lymphocytes change to B plasma cells and make anti-TPO antibodies and anti-TG antibodies. The exact cause is still under research. Possible cause include family history of Hashimoto disease, certain medication that we will discuss later in this part, often associated with the other autoimmune diseases like ulcerative colitis or type 1 diabetes mellitus. The complete pathophysiology discussed in previous lecture, where we discussed the presence of germinal center, fibrosis, follicular cell hyperplasia, and the presence of oxyphil cells. Please go and watch the complete video. Now, the postpartum thyroiditis. It is a temporary inflammation of thyroid gland that develop within the first year after delivery. It occurs soon after delivery in 70% of the women. The exact cause remain under research, but it's believed to result from immune system changes during pregnancy. Pregnancy induces a state of immune tolerance, that is, during pregnancy the immune system is naturally suppressed to tolerate the fetus. After delivery, the immune suppression rebounds, that is, after delivery, the immune system reactivate, causing overactive immune response. This rebound leads to the immune system attacking thyroid gland, causing inflammation and thyroid hormone dysregulation. The more common in women with type 1 diabetes, family history of autoimmune thyroid problems, and other autoimmune diseases. It often starts with brief phase of overactive thyroid gland followed by underactive thyroid gland, that is hypothyroidism. The affected thyroid release stored thyroid hormones, resulting in transient hypothyroidism, often mild and undiagnosed, followed by hypothyroidism. Thyroid gland is not acutely tender. Most women recover normal thyroid function. Women in whom the postpartum thyroiditis develops have 70% chances of reoccurrence after subsequent pregnancies. It occurs most commonly in women who have higher level of anti-TPO antibodies in the first trimester of pregnancy or immediately after delivery. Painless silent sporadic thyroiditis is similar to postpartum thyroiditis, except it is not related to pregnancy. Its cause include the amiodarone and immunotherapy. And now the other cause of thyroiditis, the excess of dietary iodine supplementation, is the cause of autoimmune thyroiditis, which we will discuss in the part 1. And other certain medication include the amiodarone. Amiodarone contains 37% of iodine by weight, that is, each 200 mg of tablet delivered 75 mg of iodine. This disrupt the thyroid function in two ways. The first, it induces hyperthyroidism in patients with pre-existing thyroid problems like multinodular goiter or latent grave disease. This excess iodine lead to overproduction of thyroid hormones, that is, increased synthesis of T3 and T4, due to excess iodine. This phenomenon is what we called as the Jode-Basedow phenomenon, and which we already discussed in previous lectures. And second, destructive thyroiditis due to excess iodine. In patient with normal thyroid gland, its direct toxic effect on thyroid follicular cells lead to inflammation and destruction of the gland and release preformed hormone into the circulation, and that's how the amiodarone cause the destruction of the thyroid gland. It is not a autoimmune process but rather an inflammatory one, as histologically no lymphoid follicular or germinal center present. The third one is lithium. It blocks the release of T3 and T4 from the thyroid follicular cells. Also, it accumulates in the thyroid gland and interfere with iodine oxidation, coupling of iodine with tyrosine and the secretion of the thyroid hormone. And also, lithium can increase the propensity of autoimmune thyroiditis by enhancing B lymphocyte and cytotoxic T cell activity, which leads to production of autoantibodies and autoimmune destruction of the thyroid tissue, which can manifest as either hypo or less commonly hyperthyroidism. Autoimmune thyroiditis is also associated with other endocrine deficiencies. For example, it is a part of autoimmune polyendocrine syndrome type 2, that is APS type 2. Adults with APS type 2 are prone to autoimmune thyroiditis, diabetes mellitus type 1, autoimmune gonadal failure, hypoparathyroidism, adrenal insufficiencies. Thyroid is also associated with other autoimmune disorders, for example, with pernicious anemia, Sjogren's syndrome, vitiligo, IBD, and celiac disease. And now the known non-autoimmune cause, that is painful subacute thyroiditis. It is also known as de Quervain's thyroiditis or granulomatous thyroiditis. As the name suggests, the hallmark feature of painful subacute thyroiditis is tender thyroid gland with painful dysphagia. The affected population between the 3rd and 6th decades of life. It is typically associated with the upper respiratory tract infection. For example, COVID-19 infection, mumps, adenovirus infections. The anterior neck pain in the region of thyroid occurs abruptly and may be sometimes unilateral. It may radiate to ear, mandible, or occiput. The pain may aggravate by moving the head, swallowing, or coughing. Initially, there is hyperthyroidism and later followed by the period of hypothyroidism. Full recovery occurs in 4 to 6 months. Why this is also known as granulomatous thyroiditis? Because of presence of granuloma. And what is granuloma? Granuloma is a small area of chronic inflammation in tissue made up of special cells called macrophage. In granuloma, immune cells gather tightly around the harmful material like any foreign body, persistent infection, or immune reaction, and form a barrier like a biological wall to block it off from rest of the body. And in center of this image is a harmful material, and around there is a layer of macrophage, and some macrophage fuse to form a giant macrophage called multinucleated giant cell, and around that we have lymphocytic infiltration, and in chronic case we can see fibrosis also. In this histological image we see a granuloma, multinucleated giant cells, and inflammatory infiltrate, and this is the painful subacute thyroiditis. Infectious thyroiditis, also known as suppurative thyroiditis. It is rare among the immunocompromised patient. The thyroid gland in this condition is severe, painful, and the patient is febrile with leukocytosis and elevated ESR. It is usually bacterial, but mycobacterial, fungal, parasitic infection can occur typically in immunocompromised individuals. And the last one is IgG4 related thyroiditis, which is also known as a Riedel's thyroiditis. It is a rare chronic inflammatory disease of thyroid gland characterized by dense fibrosis that replace the normal thyroid tissue and extends beyond the thyroid capsule into surrounding neck structures. Fibrosis invades not only the thyroid but adjacent tissue also. This caused the thyroid gland to become hard and fixed, and often leading to compression symptoms because of hard, fixed thyroid mass. Compression symptoms include dysphagia, difficulty in swallowing, and difficulty in breathing. Most patients are euthyroid, but 30-40% can develop hypothyroidism due to fibrotic structure of gland. This condition is considered a part of systemic fibrosclerotic or IgG4 related disease. Diagnosis is confirmed by histologically. On histology, what we see is extensive dense fibrosis. Thyroid follicles are markedly reduced or atrophied, and chronic inflammatory infiltrate, including lymphocytes, plasma cells, and scattered eosinophils.